Hey guys, nice to see you again. Let's enjoy the chest radiographs with Dr. Y. How about the mediastinal lesions? Are you satisfied? Hope to be satisfied with this session. Today's session is 27, pulmonary tuberculosis, first of the 3 sessions. Today's session will be mainly about the facts, statistics, and definition about the tuberculosis, and we will study case films at session 28 and 29. Tuberculosis is airborne bacterial infection by way of cough, speaking, sneezing, spitting. Mycobacterium tuberculosis is the germ, name of the germ, and it is also called AFB, acid-fast bacilli, because the capsule is too strong even for the acid. Once MTB is inhaled, they'll usually lodge in lung tissue. A quarter of world populations are thought to have latent tuberculosis. 10 to 15 million people have active tuberculosis in the whole world. Southeast Asia and Africa and West Pacific is the endemic area of the world. MDR-TB, multi-drug resistant tuberculosis, is increasing and it has become a problem. 27. Facts about the tuberculosis. Prolonged exposure is needed to be infected by tuberculosis, typically from close family or partners, not from casual acquaintance. Healthy person may contract latent TB, but usually does not get diseased. Later when immune system of him is weakened, they may get diseased. Without treatment, tuberculosis can be even fatal, and medicine almost always cures the tuberculosis. Persons with weak immune system is at greater risk for tuberculosis. In these cases, disease may develop even in days or weeks after infection. Active tuberculosis disease means AFB are multiplying, attacking lung or other organs such as lymph node, bone, kidneys, and brains. From lung, MTB moves through blood system or lymph system to other organs. High-risk groups for active tuberculosis are those with weak immune systems, such as baby, child, and in chronic conditions such as diabetes, chronic renal disease, heavy smokers, HIV positive or AIDS patients, organ transplant recipients, or cancer patients with chemotherapy, or autoimmune disorder patients such as rheumatoid arthritis. Let's learn about the stages of the tuberculosis. First, primary infection. This is the first stage, when immune system cells find and capture the AFB, and they may completely destroy the germs, but some germs may survive and multiply. 2. Latent infection. Primary infection is usually followed by latent infection of tuberculosis. Immune cells build wall around the lung tissue with germs. AFB cannot do any more harm if immune system keeps them under control, but sometimes germs may survive. 3. Active tuberculosis disease. When immune systems cannot control germs, they cause disease throughout the lung and other organs. Classifications of the tuberculosis. 1. Primary tuberculosis. The onset of clinical disease is less than 1 year of initial infection, which means they are not sensitized to tuberculosis. The patients are usually infants and children, usually under the age of 5, but recently adults are increasing. 2. Post-primary tuberculosis. The definition is previously sensitized to MTB. Usually the patients are adolescents and adults. There are 2 types. One is reactivation. Disease onset is less than 1 year after initial exposure. This means the germ in the original site is now reactivated, not from outside. B. Reinfection. This is second strain, not the reactivation, but the new one from the outside, usually in the endemic area. Radiologic findings of the tuberculosis. Actually, this is the most important slide of all about the tuberculosis. A. Primary tuberculosis. 1. Consolidation of middle lobe and lower lobes. 2. Lymphadenopathy. 3. Miliary micronodules. 4. Pleural effusion. Let's say again, consolidation, lymphadenopathy, miliary nodules. 4. Pleural effusion. B. Post-primary tuberculosis. 1. Centrilobular nodules. 2. TIB pattern, 3 in bud pattern of upper lobe. 1 and 2 is the same description of one thing. 3. Consolidation. 4. Ground glass opacity. 5. Cavitation. 6. Bronchial wall thickening. 7. Miliary nodules. 8. Single nodule. 9. Parenchymal bands. 10. Septal thickening. Let's do it again. Centrilobular nodules, 3 in bud, consolidation, ground glass opacity, cavity, bronchial wall thickening, miliary micronodules, and single nodule. Radiologic findings of the tuberculoma, pulmonary nodule, and actually 5% of the active tuberculosis show only tuberculoma, the nodule. Satellite nodules around tuberculoma with typically smooth and sharp margin. When tuberculoma is solitary, it mimics lung cancer. Radiologic findings of the bronchial tuberculosis. Irregular circumferential wall thickening and luminal narrowing, usually involving distal trachea, carina, and main bronchi, usually more on the left side than right side. Females are more than male patients. Radiologic findings of the miliary tuberculosis. It is a hematogenous spread, something like the cancer spread to hematogenous metastasis to lung from outside. Micronodules show random distribution. The micronodules usually show uniform in size from 1 mm to 4 mm. Micronodules are more on the lower lung than upper lung. They may show or may not show the other tuberculosis findings. Radiology of lymph node tuberculosis. They usually show unilateral on the right side, such as right hilum and paratracheal lymph node involvement. 1/3 of them show bilateral involvement. Aft contrast enhancement. The lymph nodes may show central low density of cageation necrosis and rim enhancement. The complications are obstructive consolidation or atelectasis, hyperinflation or perforation into bronchi at right lower lobe or bronchus intermedius. Radiology of MDR, multi-drug resistant tuberculosis. A. Primary drug resistance show the pattern of non-cavitary consolidation, pleural effusion, and lymphadenopathy, but in acquired MDR tuberculosis, they usually show bigger cavity, more cavities than other usual tuberculosis. We commonly or sometimes meet the tuberculosis destroyed lung. It is a descriptive term of severe sequelae after tuberculosis. B. They usually show severe lung function damage. C. Usually they are unilateral, more on the left side than right side. Usually shows the severe bronchiectasis, more cystic bronchiectasis, and lung collapse, and contralateral lung herniation to the damaged lung. And the damaged lung usually shows shrunken thorax with rib hypertrophy. I'll introduce you to radiologic findings of active and inactive tuberculosis, written by Dr. Nachapan et al. Pulmonary tuberculosis, the role of radiology in diagnosis and management in radiographics, year 2017. A. Active tuberculosis findings are cavity, consolidation, centrilobular nodules, in other words, three-in-bud pattern, miliary micronodules, lymphadenopathy, and pleural effusion. These are the most important descriptions of the tuberculosis session. B. Inactive tuberculosis findings are A. Fibronodular scars such as peribronchial fibrosis, well-defined nodule, traction bronchiectasis, upper lobe volume loss. B. Calcified granulomas or calcified lymph nodes. Let's do it again. The radiologic findings of active tuberculosis. This is very, very important. Cavity, consolidation, three-in-bud pattern, miliary micronodules, lymphadenopathy, pleural effusion. These are the findings of active tuberculosis. The patient is diseased and he or she needs medicine from the doctor. Radiologic findings of inactive tuberculosis, written by Nachapan et al. Radiographics, year 2017. The most important thing is without active findings. Without active findings. This means inactive. Peribronchial fibrosis, well-defined nodules, traction bronchiectasis, upper lung volume loss, calcified granulomas or lymph nodes. The most important finding of inactive tuberculosis, I say again, without active findings. How do you feel now? I think you did great job. Let's meet the active tuberculosis radiographic findings on session 28. See you later. Like, subscribe will be a big support to Dr. Y. Thank you very much. Hasta pronto.